Thanks. Thanks very much, Karen. So hi, everyone, and welcome to another edition of the Vancouver Bone Squad Lecture Series. As Karen says, my name is Dr. Leclerc. I'm one of the radiologists here at VGH and UBC. This week, I have the absolute pleasure of welcoming, without hyperbole, one of the most knowledgeable and effective educators of MSK ultrasound anywhere in the world today. Not just MSK ultrasound, but ultrasound in general. But I think you'll see after this lecture that our speaker has a particular panache for MSK ultrasound. So Stephen Bird is a general sonographer from Adelaide, Australia, and has over 3 decades of clinical experience. He holds a general and vascular DMU and a master's of medical sonography from the University of South Australia. He's also an honorary fellow of the Australasian Society for Ultrasound in Medicine and a life member of the ASA. And Steve is going to be talking today about the patterns of structural failure with ankle inversion injuries. And as you'll see here in a moment, the lecture is pre-recorded, but we're very fortunate to have Steve with us here, and he'll be taking any questions after the lecture is done. And I don't know if you want to make any introductory remarks, Steve. I hope I've done you justice. But
no, that's fine. Like, thank you very much for your very kind words. I hope everybody enjoys the presentation that we've recorded, and I'm very keen to take as many questions as you like at the end. So, so let's roll the video.
Okay, let's get it going.
Welcome to MSK Bone Squad. My name is Stephen Bird, and I'm a sonographer in Adelaide in South Australia. It's a great privilege to be able to present at your meeting. I'd like to talk to you today about inversion injuries at the ankle. And you notice I've got a little prop. Now, I'm not one for props, really. In fact, if you've enjoyed my material at birdultrasound.com.au, you'll notice I don't really use props. I just use lots of metaphors.
Sorry, Luck, can the audio's been muted.
Injury.
Oh, my apologies. Is it better now?
60 kilometers an hour, and I drive.
Yes, thanks.
Okay, my apologies. I'm just going to reset this because I think this is important. My apologies.
Welcome to MSK Bone Squad. My name is Stephen Bird, and I'm a sonographer in Adelaide in South Australia. It's a great privilege to be able to present at your meeting. I'd like to talk to you today about inversion injuries at the ankle. And you notice I've got a little prop. Now, I'm not one for props, really. In fact, if you've enjoyed my material at birdultrasound.com.au, you'll notice I don't really use props. I just use lots of metaphors and hopefully quite concise and logical explanations to help you navigate around the musculoskeletal system. But I think in this case, this little skeleton of the foot and ankle is going to be quite handy. Now, the way I think about an inversion injury of the ankle is a little bit like thinking about a car accident. This is a metaphor I like to use to get my head in the right space to work out what's gone wrong with the ankle after an injury. Now, if you imagine I drive my car at 60 kilometres an hour and I drive it into a big old river red gum tree down here in Adelaide, that means my car's going to stop. It's going to go from 60 kilometres an hour to 0 in a fraction of a second. Now, that's an awful lot of kinetic energy to be dissipated rapidly, and hopefully I don't get injured in this accident. So the car's very clever. The car can get rid of a lot of that kinetic energy and dissipate it through the use of things like crumple zones. And of course, the airbags will fire and the pre-tensioner on my seatbelt will work effectively. And hopefully, after all that tech has played its part and done its job, I could walk away from the accident with not too much of an injury. If you think about an inversion injury of the ankle in the same way, when I stumble, so say I'm walking towards you now and I stumble, trip over something slippery on the ground, I've got a certain amount of kinetic energy that's going to have to be dissipated by my ankle. Now, Mother Nature's provided me with lots of different ways to get rid of that kinetic energy. The ligaments in my ankle are made of collagen. They can stretch a little bit. The bones can flex a little bit. And the muscles can let out a little bit of length as well to try and take care of some of that energy. And hopefully what will happen is I can simply stand up, dust myself off, look around and think, nobody saw me. I'm not going to die of embarrassment and get on with my day. Unfortunately, though, with most inversion injuries, especially in the sporting arena, there's more kinetic energy than Mother Nature can take care of. So if I roll my ankle very severely and all of those little bits of tech in my body fire off their response and they can get rid of a bit of the energy, but there's still more to get rid of, I need other mechanisms to get rid of that kinetic energy. And I think of it as having 5 potential ways to get rid of this energy. So when I approach an ankle ultrasound after an inversion injury, I look through these 5 pathways to try and work out which method the patient has used to dissipate the energy. The first thing is an old-fashioned orthopedic fracture. So if you simply fracture your distal fibula, or perhaps you do a trimalleolar fracture where you have the distal fibula, the medial malleolus of the tibia here, and the posterior process of the tibia, if these three little pieces of orthopedic architecture fail together, that's a trimalleolar fracture. You may, of course, also have a base of fifth metatarsal fracture. Now, these patients don't come for an ultrasound. They come in, they've got a fairly significant ankle injury. They go off, they see them, they go to radiology, have their x-rays, they see there's been an orthopedic fracture, and they just go to the orthopedic clinic, so they never come for an ultrasound. The patients that we see are not from that first category. The patients that we see are from the other 4 categories. Now, the second category is where you try and disassociate your fibula from your tibia. Now, if these 2 bones, which are bound together tightly, can move apart from each other, this is a very effective way of getting rid of some of the energy from the accident. Now, the structures that have to fail for this to happen are the anterior inferior tibiofibular syndesmosis. So this structure runs obliquely between the fibula and the tibia, and it runs quite obliquely at this angle, almost up towards the patient's opposite knee. If that fails, it may also fail in association with the posterior counterpart, the posterior inferior tibiofibular syndesmosis, and this runs at almost a mirror angle in the posterior ankle. And then, of course, there's another structure, the interosseous membrane that sits between the tibia and the fibula, running up through the calf here, and that can tear as well. So these are what we call a high ankle sprain. And the one that we most commonly see fail is this anterior inferior tibiofibular syndesmosis. Now, when this fails, the patient won't walk into the department. They'll come in moon boot, crutches, wheelchair, they'll be hopping along. They're not going to weight bear, because if you try and weight bear, once you've disassociated your fibula from your tibia, these 2 bones will separate as the talus drives up in between them. And this is going to stretch and continue to tear that interosseous membrane, which is exquisitely painful for the patient. The third way that you can disassociate the kinetic energy is to try and disassociate your hindfoot from your fibula and your tibia. So if you think about the ligamentous structures that you have holding your hindfoot to the tibia and fibula, they are, of course, the ones that we very commonly see injured in our daily practice. It's the anterior talofibular ligament, the calcaneofibular ligament, and then on the contractus side, we see either compression or stripping injuries of the deltoid ligament complex between the calcaneum, the talus, and the medial malleolus of the tibia. So a disassociation of the hindfoot from the tibia in fibula is a very, very common, in fact, the most common way that we release energy, that kinetic energy, in an inversion injury. The fourth way to consider is what I refer to as a Chopart line failure. Now, the Chopart line is the line that connects the midfoot from the hindfoot. Now, the midfoot is made of a variety of bones. It's made of the cuboid and the navicular and the 3 cuneiform bones, and the hindfoot is made of the calcaneum and the talus. The line between the calcaneum and the talus and the navicular and the cuboid, this line that you can see straight through here, this line through here is the Chopart line. And if you disassociate your midfoot from your hindfoot through the Chopart line, you're going to see classic injuries of the dorsal talonavicular ligament, and this will very commonly take a small avulsion from the navicular end. You'll also see very commonly a avulsion fracture from the anterior tubercle of the calcaneum here, where the bifurcate ligament origin is, and the bifurcate ligament consists of the calcaneocuboid ligament running from here to the cuboid, as well as an associated sling that runs from the anterior tubercle of the calcaneum across to the navicular bone. When that bifurcate ligament is put under strain as part of a Chopart line injury, it very commonly causes an avulsion fracture of the anterior tubercle of the calcaneum. There's also the remainder of the joint capsule between the calcaneum and the cuboid running down towards the plantar aspect of the foot. And along this line here, there's a couple of other little discrete thickenings in that joint capsule, which are also extra little calcaneocuboid ligaments that can also fail as part of a Chopart line injury. The fifth way that we can fail is a disassociation of the forefoot from the midfoot. Now, the forefoot, of course, is made of the 5 metatarsals and the associated phalanges, and the midfoot is made of the cuboid, the navicular, and 3 cuneiforms. Now, if you look at the medial aspect of this foot, you'll see how short that first metatarsal is. And this is not by accident. It's much shorter than the other metatarsals. And what this means is that this line through here, which is known as the Lisfranc line, is not a straight line. If this was a straight line, it would be very easy to disassociate your forefoot from your midfoot, and would have long lines of patients outside of the casualty departments all around the world where they've simply pulled their forefoot off of their midfoot. This doesn't happen because of this very cunning design feature. The design feature that's important is the short first metatarsal, or the short first ray, as you might refer to it, and the very large medial cuneiform. This creates a step in this Lisfranc line so that the second metatarsal base does not line up with the first metatarsal base, and in fact lines up with the medial cuneiform. And between the medial cuneiform and the second metatarsal base, we have the dorsal Lisfranc ligament. So a disassociation of the forefoot from the midfoot is called a Lisfranc disassociation. So when this person has the unfortunate luck to have the large inversion injury, they really had these 5 options to dissipate the energy. With a bit of luck, they don't take option 1, they don't go for an orthopedic fracture, but they have to get rid of the energy somehow. So I put my detective hat on and I go about trying to establish whether or not they've disassociated their tibia from their fibula, or disassociated their tib and fib from their hindfoot, or disassociated their midfoot from their hindfoot, or disassociated their forefoot from their midfoot, because they're the 5 options that I've got. So I go around very quietly and carefully and have a look for a pattern of injury that is going to be quite predictable. You are certainly going to have patients where they have multiple methods of getting rid of this kinetic energy. So they may have decided to disassociate their hindfoot from their tibia and fibula, for example. We're going to see this so commonly where their ATFL is torn, their calcaneofibular ligament is torn, and they've got a bit of degloving of the medial joint capsule from the medial side here as the deltoid ligament and the flex retinaculum degloved from the medial malleolus. In that same patient, however, there may have still been excessive kinetic energy that still needed to be dissipated, and they may also then suffer a disassociation of their fibula from their tibia with an inferior tibiofibular syndesmotic injury, so a high ankle sprain. So you have a conjunction then of a high ankle sprain as well as an ATFL, CFL and medial joint capsule injury all in the same patient. But whichever way it rolls, these patients are going to fall into one of these 5 patterns. Another clue that I like to take into my ultrasound room when I meet the patient, and remember that the patient's the most important thing in that room. I can talk to the patient, I can get a good clinical history from them, and I can have a good look at their foot to see what it looks like and where the bruising is and where the swelling is. Now, if I see lots of swelling on the lateral side of the ankle here, the first thing that comes to mind is, where did the excess fluid come from? Now, the easiest source of excess fluid in the subcutaneous space is from a joint capsule. So if you tear your anterior talofibular ligament, for example, that's going to release the fluid that's inside the ankle joint. So the synovial fluid from inside the ankle joint will then move into the subcutaneous space, and we get this very rapid accumulation of swelling around the lateral malleolus, etc. The other pattern that I see commonly is where there's not just swelling, but there's lots of bruising. Now, synovial fluid is clear. It's sort of like a clear serous colour. So that's not going to cause bruising if that leaks out. And if you tear an anterior talofibular ligament through the centre of that ligament complex, it's not going to bleed much either, because it's really just a pure sheet of collagen. If, however, you have a small avulsion fracture, and that avulsion fracture might be a small piece of talus that comes off as part of an ATFL injury, it might be where the anterior tubercle of the calcaneum has come away as an avulsion fracture as part of a Chopart line injury, then these small avulsion fractures are going to bleed prolifically. And that blood's going to give quite a lot of bruising to the lateral side of the foot. So if I see a lot of bruising, I'm on the hunt for a little avulsion fracture, or even perhaps an orthopedic fracture. And if there's just swelling, I'm really just looking for a ligamentous injury that's opened up a joint capsule. Follow this logic and see how you go, and you should be able to solve the riddle of the ankle inversion injury. For my standard approach to an ankle inversion injury, I always like to start by having a look at the main articulations themselves. So we line up the 2 bones we've got here. This is the tibia and this is the talus. So this is the anterior ankle joint we're seeing here. You'll notice that the talus has a really interesting shape. There's a little bit of hyaline cartilage on it here, and then there's a little neck here, and then it comes up to a high point, and there's a bit more hyaline cartilage over here. The reason it's such an unusual shape and structure is because this piece of hyaline cartilage articulates with the tibia as part of the ankle joint, and this bit of hyaline cartilage here articulates with the navicular bone, which is here. You can see in this volunteer that we don't have any joint effusion whatsoever. We've just got a normal anterior ankle fat pad sitting in here. And even in the neck of the talus, which is this area here, it's devoid of any fluid. A little bit of fluid in this location is quite a normal variant. I wouldn't be concerned if I saw a small amount of fluid in that location. What I'm really looking for mainly, though, is the presence of a large effusion. When we have a large effusion, the joint capsule actually hugs this hyaline cartilage, sits right down on top of it here, and that will be displaced anteriorly along with this anterior fat pad. And so you get a fluid collection in this location. And of course, with an inversion injury, if someone's had ankle trauma, not only am I looking for a presence of an effusion, but I'm also considering the concept of seeing a hemarthrosis, or even worse, a lipohemarthrosis. just for ease and also a bit of a habit of mine, the next thing I'll have a look is just come straight down through the midfoot here. And this brings us through a couple of articulations. So this is the talo-navicular articulation here. So this is the dorsal talo-navicular ligament. You can see it bridging across these two bones here, right across that joint space there. And this is, of course, one of the ligaments in the Chopart line of the foot. So by seeing this articulation here, I can already get a bit of a glimpse of the fact that the Chopart line does not seem to have been involved in the trauma here. Then I come straight down the foot a little bit further, and this is the navicular intermediate cuneiform articulation. And then this is the intermediate cuneiform base of second metatarsal articulation. Now you might think to yourself, why are these small articulations important? But with any type of ankle trauma, I think it's just worth having a look down through the midfoot to see if we can see any damage to any of these other smaller minor articulations, particularly if the patient has any point tenderness there. The next thing I come around to is the lateral malleolus. So you can see the lateral malleolus of the fibula here. And on top of that, you can see our peroneus longus and peroneus brevis tendons. Now, I'm not interested in these just yet. I'm still focusing on articulation. So as I come around the corner here, and I come around these two peroneal tendons, you'll see underneath, you can see the CFL, the calcaneofibular ligament arching underneath it here. Now, this is really a terrible image of the CFL because I haven't tried to optimize it at all yet, but we'll get to that a little bit later. What I'm looking for, though, is this articulation here. So this is the calcaneum here, and this is the talus, which means this is the subtalar joint. So, of course, the ankle has two major articulations, the ankle joint and the subtalar joint. If I then keep this articulation in focus, I can really see that there's no joint effusion. If there was a significant joint effusion, I'd see fluid bellowing out through the joint capsule here. And then as I keep coming a little bit further distally, I'm just coming further around following the peroneal tendons, sort of just coming off of the calcaneofibular ligament now. You'll see that the bone more posteriorly here, which is the calcaneum, persists, and the bone that was more anterior, which was the talus, has now disappeared. And what we're left with is this large triangle of fat here. And if I just increase my depth a little bit, you can really appreciate there's a big gap here between this bone that's the calcaneum and this bone right over here, which is the talus, and this is the sinus tarsi. Now, in a person that's had trauma to their ankle, if I see fluid in this location here that is monoloculated and compressible, this is consistent with a subtalar joint fusion. And then, of course, if I see blood here, we have a subtalar joint hemarthrosis. And that would indicate the strong possibility then of a fracture of either the talus bone or the calcaneum that's bled inside this joint. What I'm doing now is I'm just placing my thumb underneath the lateral malleolus, and I'm placing my transducer just superior to my thumb. I'm parallel to the sole of the foot, and I have the patient in a bit of passive inversion of the ankle joint. And we can line up two bones here. This is the fibula and this is the talus. And this shows the anterior talofibular ligament. Now, this is a very important ligament because it's one of the weakest ligaments in the ankle, the one that is most susceptible to damage during a standard inversion injury. In this case, you can see that it looks like it's in good condition. Underneath it, there's no joint fluid. A smaller bit of fluid here would not bother me. The structure we can see deep to the ligament here is just a bit of fat sitting inside the ankle joint. That's quite normal. And there's just a little trace of fluid sitting there. What I do next is I block my fibular end of my transducer. I keep this end absolutely stationary, and I move the distal end, so the talar end of the transducer, pointing up towards the patient's opposite knee. So what you'll notice as we go is you'll start to see some hyaline cartilage here forming on the talus. In fact, this is a very good clue. If you're looking for the anterior talofibular ligament, but you can see hyaline cartilage on the talus, it tells you that this end of the transducer, the distal end of the transducer, is too proximal, and you need to rotate this end of the transducer towards the sole of the foot. And it's a very common reason for people not being able to identify the ATFL is because they're in the wrong location on the talus. Of course, a ligament cannot attach to hyaline cartilage, so you can bear that in mind. But as we continue, you'll see that this bone, the talus, will disappear, and the next bone that appears will be the tibia, and now we have the anterior inferior tibiofibular syndesmosis. So now we've found the anterior inferior tibiofibular syndesmosis. If we do a little bit of eversion of that ankle joint, you can see the way that just tightens it up a little bit. So you've got that nice collagen lines down. You can see the attachment. You can see it stressing it there, and then let it relax a little bit. See it hammocks a little bit. Then you can tighten it and see it stressing it again. And this is, of course, the syndesmotic structure that holds the tibia to the fibula. And when this fails, this is, of course, part of a disassociation between the tibia and the fibula. It's also known as a high ankle sprain. And just remember, it might also involve the posterior component, the posterior inferior tibiofibular syndesmosis, and then it may also involve a tear of the interosseous membrane between the tibia and the fibula higher up in the calf. What I've done now is I've just come right up the calf. So I'm in about the mid to distal third of the calf. And here on the medial side, we can see the tibia, and here on the lateral side, you can see the fibula. And these are the muscles of the anterior compartment of the calf itself. And of course, between the fibula and the tibia here is the interosseous membrane. And what I like to do is just walk up and down this interosseous membrane as I'm doing now, just looking to see if there's been any perforation or any tearing of this interosseous membrane as part of a high ankle sprain. When you see such an injury, you'll see there's obviously a gap here, but you'll also have a hematoma that sort of straddles across the borders from one side to the other, heading from this anterior compartment through to this posterior compartment. You can see a rather large artery here, and this is the anterior tibial artery here. You can then turn long axis on the same interosseous membrane, and while you tend to lose your anatomical bearings a little bit because it just all looks like muscle now, you know that this layer through here is the interosseous membrane, and you can walk up and down it in the long axis now, just looking for any evidence of any perforation or failure of that membrane. Next, I'm just going to walk down these peroneal tendons and have a look at a few other pieces of anatomy. So this is peroneus longus, this is peroneus brevis, and this is the fibula here. The first thing I'd get to is this structure that's arching over the top, and this is the superior peroneal retinaculum. So that rides over the top of the peroneus longus and brevis tendons. With an inversion injury, it's quite possible to separate this superior peroneal retinaculum from the fibula. As we come down around the corner now, so I'm coming around that bony malleolus there, we get to the CFL. So this is the calcaneofibular ligament. And you can see the CFL arching underneath here quite beautifully. There's the fibula here. This is the calcaneum here. This is peroneus longus, peroneus brevis. Now, to improve the visualization here, if we just do a little bit of inversion and dorsiflexion, so bring the patient's toes up towards their chin, you can see now with a maximum amount of inversion and dorsiflexion, the calcaneofibular ligament is a little better seen, particularly here at the fibular end. Although we're getting a good look at it right across to the calcaneal end as well here. As I do a little bit of dynamic assessment, I'm really pushing the dorsiflexion and the internal rotation now, or inversion rather. And you can really see the way that it lifts up those peroneal tendons. And then if I let that go, you can see the way they drop down again, has a real trampolining effect. This is quite an effective way to have a good look at that fibular attachment. Although bear in mind, if the calcaneal attachment looks as bright and as fibrillar as this one does, then the fibular attachment really has to be intact as well. If you see a little bit of fluid, which we can see there, just sitting underneath that calcaneofibular ligament, so this small amount of fluid here, this is fluid in the subtalar joint because this is in fact the calcaneum, this is the talus, and this is the fibula. So now we've got three bones that we're looking at here. So any fluid in this location here would belong to the ankle joint, but this is a really common location for fluid here, and this is in the subtalar joint. And in fact, when we have a failure of the calcaneofibular ligament, where it significantly tears through the middle, the subtalar joint often empties the fluid contained within it into the peroneal tendon sheath, and that can be a good clue that you've had a CFL failure. I'm now going to just quietly keep moving down these peroneal tendons so we can see peroneus longus sitting on top of peroneus brevis. There's the subtalar joint, and we're past the CFL now, and now we're dropping into the sinus tarsi. And this is that little bit of fluid that I spoke about before, this little tiny drop of fluid here. It's monoloculated, it's a little bit compressible, and it's sitting in this back corner of the sinus tarsi. Here's the talus here, here's the calcaneum, and that little bit of fluid there is just a tiny bit of fluid we've milked out of that subtalar joint. As you come down the peroneal tendons in their short axis with peroneus longus and peroneus brevis, you can see the CFL passing underneath it. Once we get past the CFL, you can see them separate slightly from each other. They're no longer sitting on top of each other. And then you can see a bit of a hypoechoic band running around the peroneus brevis tendon. And then that's shortly accompanied by a bigger, thicker band running around the peroneus longus tendon. And these are the two straps of the inferior peroneal retinaculum. As these come into view, you know you're about to see the peroneal tubercle, and this is in fact the peroneal tubercle here. So when peroneal tendons get into trouble, it really comes in two types. Peroneus brevis gets into trouble at the lateral malleolus through a compressive effect from peroneus longus, and peroneus longus gets into trouble right at this level here, at the level of the inferior peroneal retinaculum and the peroneal tubercle, and this is a stenosing tenosynovitis, very similar to what abductor pollicis longus and extensor pollicis brevis suffer in extensor compartment 1 of the wrist. It really is de Quervain's disease of the lateral ankle. I'm now going to continue to follow my peroneus brevis tendon all the way down, and I'll follow it all the way down to the base of the 5th metatarsal. And then we've arrived at the base of the 5th metatarsal here. If you look just laterally here, you'll see a little triangle of tissue sitting on the side of the base of the 5th metatarsal. That's the lateral band of the plantar fascia. I've now spun around into the long axis of peroneus brevis, and you can see it attaching onto the fifth metatarsal base here. I'm not really worried about the insertion of peroneus brevis. I'm more concerned about the orthopedic architecture of the fifth metatarsal itself, looking for a Jones fracture. And you can see as I come down through the neck and towards the shaft of the fifth metatarsal, there's no fracture here. Coming back to peroneus brevis, though, you can see it attaching here. And I always feel like it's worth just having a look just around to the side of the base of the fifth here, and you can see this big bow tie shaped structure that opens up, this big triangle that opens up here, and this is the lateral band of the plantar fascia attaching onto the fifth metatarsal base as well. And this is often where you'll see fractures coming through here, because it's not so much peroneus brevis that causes the fractures of the base of the fifth, it's really this lateral band of the plantar fascia, and you can see how it has a really broad attachment. Of course, the lateral band of the plantar fascia doesn't have any muscle to release any tension, and so it's a very common cause of fractures in this location. From this position here, it's really quite easy then to navigate your way to the Chopart line. So we're at the base of the fifth metatarsal. So if I then come a little bit superiorly, you then really arrive here at the calcaneocuboid articulation. So this is the calcaneum here, and this is the cuboid here, and you can see this beautiful long oblique piece of collagen that runs all the way through here. And this is the calcaneocuboid ligament. So this is part of the bifurcate ligament. There's also another component that goes from the calcaneum across to the navicular bone. And then if we come back down this calcaneocuboid articulation, you'll also see there's another small ligament here. And there's a series of these small ligaments that really make up the joint capsule between the calcaneum and the cuboid. The most common one that I see injured is not so much these small minor ones, although these may be involved, but the most dramatic thing that I see most commonly is where this anterior tubercle of the calcaneum is fractured off with an avulsion fracture as part of an injury that involves the release of energy through the Chopart line, and you'll see a fracture in this location. The distal end of the calcaneocuboid ligament right down here is rarely involved. This is a fairly benign area here. It's really this proximal end where the avulsion fractures are very, very common. You will have already thought about the Chopart line when you're having a look at the dorsal talonavicular ligament, but it's an easy thing to remind yourself about the Chopart line. If you start from this location here where you have the calcaneocuboid ligament, and then walk the transducer straight across the dorsum of the foot, and as you arrive at the dorsal aspect of the foot here, you arrive very safely at the next part of the Chopart line, which is the talonavicular ligament, which of course we assessed earlier in the examination. On the medial side of the ankle, I'd like to have a look at the medial joint capsule, which we otherwise know as the deltoid ligament structure. People get very confused about the deltoid ligament and really make it overcomplicated, I feel. If you've had someone that's had an ankle injury, I think you can divide it into two simple parts where the majority of injuries occur. And I simply follow tibialis posterior down. And as you follow down tibialis posterior, you can see the flexor retinaculum going over the top here. This is flexor digitorum longus, and this is the neurovascular bundle here with our posterior tibial arteries and veins and the accompanying tibial nerve branches. As we come around that malleolus, I'm just waiting for the tibialis posterior to free itself of that medial malleolus, and it's done so now. So now you can see that it's actually sitting on a structure that's made of collagen. This structure that's made of collagen is not terribly attractive. This is the tibio-talar part of the deltoid ligament complex. And this is the part we're going to have compression injuries. You can make it a little bit more attractive by using a bit of eversion and dorsiflexion. You can see as I've just put that bit of stress on the ankle there, you can see the way that it's tidied up those lines of collagen a bit for me. And you can see this very thick external layer here that's nearly pure collagen. And underneath that, you have a more striated, slightly fatty and also striated with synovial material, which is part of the deep part of the capsule of the deltoid ligament. What I'm looking for here is a couple of things. The first thing I'm looking for is any collision fractures. So when the medial malleolus collides with the medial border of the talus as part of an inversion injury, you can then generate small collision fragments where small pieces of the talus or small pieces of the medial malleolus become dislodged, and they'll sit in this location here. Another very common entity that we'll see is some contusion. So immediately after the injury, this part of the joint capsule becomes compressed between these two bony landmarks, and the ensuing contusion will mean that it will look swollen and edematous. And if you put the Doppler on it, you'll see increased flow in it. If that Doppler persists beyond a couple of weeks, then we can also then start to consider the concept of a chronic posteromedial joint capsule synovitis, which is given the name of a POMI lesion, POMI, or posteromedial impingement. However, this diagnosis can really only be made a couple of weeks or more after the original injury. I've now moved the transducer just a little further along the length of tibialis posterior, where we were having a look at the tibio-talar part of the deltoid ligament complex. Here's tibialis posterior here, and you can see over the top, we've got this beautiful flexor retinaculum. You can also observe from underneath, you can see the joint capsule of the medial ankle coming up from underneath. And at this point here, these two structures actually collide. So you can see we have the flexor retinaculum and the medial joint capsule, i.e. the deltoid ligament, coming together and forming a conjoint structure. I'm not sure what to call this structure. We came up with a cute little name, the liganaculum, because it's a ligament and a retinaculum that are joining together and making a single structure. And then you can see the way that this structure then attaches onto the medial malleolus here. And you can see how deep and broad it is. It comes all the way across right over to here. This beautiful collagen here can be stripped away from that medial malleolus. And this is a type of degloving injury that's not uncommon with inversion injuries to the ankle, and it's very, very painful. When you deglove the medial joint capsule and the flexor retinaculum from this medial malleolus here, it usually takes a bit of periosteum with it. When I say periosteum, you need to consider that this is an enthesis. And because it's a fibrocartilage enthesis, the anatomy that we have in an enthesis is we have soft collagen, then we have this hypoechoic layer. You can see this thin black line through here. Now, this thin black line is actually unossified fibrocartilage. Underneath that, we have the echogenic line, what we consider to be the bone when we look at it sonographically, but this is actually calcified fibrocartilage. And immediately deep to that, we have the cortical bone. So when we strip this medial joint capsule and the flexor retinaculum away from the medial malleolus, what we get is a degloving injury that certainly very commonly removes the calcified fibrocartilage from the periosteal bone underneath it here. And this is the echogenic line that you'll see stuck to the removed collagen as it strips away in that degloving injury. What I've now done is simply laid my patient prone. I'm going to come around these peroneal tendons and their short axis again. It's really going to highlight to you the difference it makes for the calcaneofibular ligament. This is peroneus longus and brevis here, and we're now starting to see the calcaneofibular ligament here. But just have a look at the tightness of it. Can you see the difference in tension that you're getting in this CFL? Now we've got the patient prone. I really haven't bothered to put the patient into any inversion or dorsiflexion stress maneuver at all. Just got the patient laying relaxed in a prone position, but definitely you can see this fibular end of the calcaneofibular ligament with a lot more definition. What I can then do is I can turn myself short axis on that calcaneofibular ligament. So I'm now around short axis on it, and you can see it beautifully just here. It's like an oval shaped structure, almost cord-like, like a rope. I can follow it now to the calcaneal insertion. You can see the calcaneal insertion just there. It's a very benign area. As you're heading towards the fibula, keep following this oval shaped structure. And you can really account for the anisotropy. You can see it now going underneath my peroneal tendons here. So there's the CFL. There's my peroneal tendons going over the top and going right past them there. And again, watch how beautifully I can account for anisotropy here. And we're just going to arrive now at the fibula. And this is really a nice example of how you can actually see a little fossa on the fibula here, like a little facet that's made especially for it. And while I've got a bit of anisotropy here that I can't quite get rid of, we know that that piece of collagen there belongs to the CFL right at its fibular origin. And you can follow it back, and you can follow it all the way back underneath the peroneal tendons and all the way to its calcaneum attachment here. So you can really walk back and forwards along the length of the CFL with the patient prone here, and you get a really good look at that with only a minimum amount of anisotropy and a lot more detail and architecture definition that you're getting compared to doing it with the patient supine. Next, I'd like to share with you some clinical cases from my own clinical practice that highlight the range of injuries that you can expect to see when you have a traumatic injury of the ankle. It's worth remembering first that the ankle can do two movements. There's dorsiflexion, plantar flexion, and then it can also do this sort of scissoring side-to-side movement. Now, the dorsiflexion, plantar flexion is using this blue joint here, which is the ankle joint, and the side-to-side is using the green one, which is the subtalar joint. So before I go any further with the examination, I'd like to examine those two joints. I also like to consider the other weaknesses inside the foot, which include the Chopart line, which is right through here where the green line is. This is, of course, the calcaneum and the talus. This is the Chopart line. This is the cuboid bone. This is the navicular. So you can see the way that it is a nice clean line through the foot there. And if we separate our midfoot from our hindfoot, we're going to break through that line. That's going to be a Chopart line failure. And then the other line, of course, is the Lisfranc line, and that sits between the midfoot and the forefoot. So as I mentioned, the first thing I'm going to do is have a look at my two primary articulations. So this is a simple image of the anterior ankle joint. This might as well be a normal healthy volunteer. This is quite a normal looking ankle articulation. This one has an effusion, which is a fairly non-specific finding, but could well be related to some synovitis or osteoarthritis, or perhaps an injury of this ankle joint. But these two are quite a specific finding. This case and this case here have the same sonographic diagnosis, and that is of a hemarthrosis. So this is a blood-filled joint. And really, whatever I see next on the ultrasound doesn't matter too much, because by definition now, this patient is very likely to have a fracture of either the talus, tibia, or the fibula, because it's bled inside the ankle joint here. And of course, talar dome fractures, we really have no chance of seeing on the ultrasound, and they can be notoriously difficult to see on the plain radiographs. So these patients will head off for cross-sectional imaging. This is a subtalar joint. You can see as I come down the peroneal tendons, you drop into the subtalar joint there, and now we drop into the sinus tarsi. And as I drop into the sinus tarsi, in that classic location, you can see there's a fluid collection. But if you look carefully at that fluid collection, you can see that it's got two layers. So there's a fluid level there, and the bottom layer is the denser red blood cells, this layer down here, and this is the more plasma part of the blood. And this is a separating hemarthrosis. Now, hemarthrosis in the subtalar joint would make me very suspicious that we're either going to have a calcaneal or a talar fracture. So again, this patient will head off for cross-sectional imaging. Let's go through our 5 methods of dissipating the energy that we've been talking about with these inversion injuries. So method 1 is an orthopedic fracture, and this is a classic base of fifth fracture here. You can see the peroneus brevis attaching onto the base of fifth in the long axis as we are now, and you can see the little crack in the cortex there. So this is an orthopedic fracture, just a small Jones fracture. Here's another nice example of a Jones fracture. You can see it's slightly more displaced than the last one. This is scanning through in short axis, and this is in long axis, and you can see the slightly displaced fracture there at the base of the fifth metatarsal. Method 2, of course, is to separate your tibia from your fibula. So a disassociation of these two bones is really dramatic, and the most common thing that we see sonographically is when the anterior inferior tibiofibular syndesmosis fails. And another thing that I see very commonly when that does fail is exactly this finding here. And this is quite a large avulsion fracture. So in this case, it's quite a big piece of the tibia that's been yanked off here. If you look anatomically on a cadaver specimen, like a prosection at the anterior inferior tibiofibular syndesmosis, you really appreciate how broad and how strong it is. So to disrupt it, it very commonly will take a piece of the orthopedic architecture with it. Here's another example. This one hasn't taken any piece of bone with it, but you can see if you contrast the normal side to the symptomatic side here, you can see the anterior inferior tibiofibular syndesmosis has failed through the middle. And really what we have in its place here is just a hematoma. And another classic finding, which you can see here, is the echogenic material that bubbles up through the area here where the syndesmosis should be. And this is some fat that's just come and sitting in that space where the syndesmotic apparatus should be. It doesn't have to be an injury that is associated with an ATFL injury. And this is an example here. If you watch this video clip from the beginning here, you can see at the beginning of the clip when it comes around that the ATFL is perfectly intact. And this is not an uncommon finding with a high ankle sprain injury. There's the ATFL, it looks beautiful. But then as we swing around, keep the fibular end of the probe still and move the other end of the probe up towards the tibia, you can see the AITFS has failed here. And again, you've got that classic fat sign where you've got a bit of fat that's sort of sitting in the place where the syndesmosis should be. You can see that the tibia and the fibula have widened apart from each other compared to the contralateral side where you have this beautiful tight syndesmotic arrangement here. When I have a failure of the AITFS, I also now look at the posterior inferior tibiofibular syndesmosis. So laying the patient prone, having the one end of the transducer on the fibula, and then pointing the tibial end of the transducer towards the patient's contralateral knee will give me this nice image here. And you can see in this case here how from the tibial end, the PITFS has a small avulsion here. And there's certainly been, perhaps not a complete disruption, but certainly a little tug injury of the PITFS here in this instance. And of course, if you look at the AITFS in the same patient, there's a classic fat and hematoma type arrangement sitting where the syndesmotic structure used to live. One more example here, and this I really like this example because I'm applying a little bit of stress to it. You can see it wobbling around, and you can also see what I call the periosteal stripping. So you can see that white line there, and this is a piece of the tibia that's been sharded off as the syndesmotic apparatus has been pulled away from the bone. This is how I perform the stress test. I bend the patient's knee and I cup their calcaneum in my left hand, and then using my right hand to hold the transducer, I place the ankle into external rotation. And the external rotation works perfectly to open up the anterior inferior tibiofibular syndesmosis. It's interesting, when I do a posterior inferior tibiofibular syndesmosis, I use the opposite action. So I use an internal rotation to try and tighten the posterior inferior tibiofibular syndesmosis, and of course then open up that gap between the tibia and the fibula. In these patients also, once I see an ATFS failure, I then also go up and have a look at the interosseous membrane. So you can see what I've done here is I've come about halfway up the calf, and you can see between the tibia on this side and the fibula on this side, you can see the way that the interosseous membrane is separated here, and you've got a hematoma straddling between the anterior compartment and the posterior compartment of the calf. And in the long axis, you can see this rather large hematoma, and you go from a very strong line here of the interosseous membrane to a very weak line here, which is almost certainly just being produced by some partial voluming from the beam width. These are just more images to show exactly the same thing. And just to show that it isn't just a sleight of hand, you can see that this is the symptomatic side. We've got this clear gap here in the interosseous membrane. And on the asymptomatic side, we've got this beautiful, well-maintained, strong white line here of the interosseous membrane. This is now method 3, where we're separating our hindfoot from our tibia and fibula. And first of all, we need to find the ATFL. So I run my thumb up underneath that lateral malleolus, and then I place the transducer on top of my thumb. You can see the way that the ankle is in some fairly passive inversion, and the way that the transducer is parallel to the sole of the foot. This places you immediately on the ATFL, and the picture you can see here is exactly the picture that you can expect to see when you look up at the screen. These are examples of ATFL failures, and you can see the clefts here. I'm just using a bit of transducer pressure here, which is not the best method, I don't think, but it's a reasonable way to test the integrity of the ATFL. These little echogenic foci you can see through here are small little bits of avulsion that have been removed from the talus. And here's one with a larger piece of talus avulsion. And you can see the way the transducer pressure is quite effective in just demonstrating that that little fragment is mobile there and no longer attached. These patients, of course, will have significant bruising because this is now a small piece of orthopedic injury, and the prolific bleeding that these cause will cause bruising rather than just swelling. This is a method developed by a good friend of mine, Quanson Searle in Melbourne, and it's called the Quanson Modified Draw Test. It really harks back to the old-fashioned way we used to do plain radiographs and stress test the ankle before ultrasound became available to look at ligaments around the ankle. If you lay the patient prone, the couch actually does the job of the left hand here. And the left hand of the sonographer can do the job by pushing down, which is doing the job of the right hand here with the clinical test. The right hand of the sonographer holds the transducer in the standard position and just gently apply downward pressure. It's not as painful as you'd think if you just apply a gentle graded compression downwards. And when you do that, you can really see the way the ATFL opens up. Because what you're challenging here is as you're pushing down on the calcaneum, you're moving the talus down towards the floor, and the ATFL should stop that movement. But you can see here, of course, it's broken, so it has an inability to stop that downward movement. Here's another nice example. In this case, you can see I'm applying a fair bit of stress. In fact, so much I just get a little bit wobbly there because I'm pushing quite hard. But you can see the way this little piece of avulsion, this is actually from the fibular end, has come away here, and you can see the way the talus moves towards the toes. So this movement of the talus away from the fibula and that little bit of an avulsion fracture gives you the diagnosis. These are more examples of the Quanson modified draw test. And this ligament here, you can really see it's almost like a piece of chewing gum now, the way that it's just sort of sinewy and has no real integrity. And you can see how mobile the talus is moving to the right of the screen there. So this is now my standard way of stressing an ATFL. And if you just do it gently with graded compression and get the patient's confidence and just push down with just a firm hand, you can really be sure about your diagnosis, and you can see if it is a partial tear, a complete tear, whether there's any avulsion component, etc. I like to think of the ATFL and the CFL as a continuum as well. So this is the CFL here, and you can see clearly it's been disrupted at the fibular end because it's all boggy and swollen there. But then as we come up over the top, you can see the way that it really just continues on as the ATFL. So here's the CFL heading up towards the fibula, but right over the top of the fibula, all of this sheet of collagen is disrupted, and there's the ATFL that's disrupted as well. So when you disassociate your hindfoot from your tibia and the fibula, quite often the ATFL and the CFL will fail simultaneously, where they'll both sort of deglove from the fibula during that injury process. This is a really common bruise pattern that we see with inversion injuries. This is a really typical bruise pattern that from an ATFL, CFL combination type injury, where there's been a little bit of an avulsion that's led to this bruising here. And then on the other side of the ankle, you get the contra coup bruising from the collision on the medial side, the so-called POMI lesion. and the contusion injury that we get of the deltoid ligament complex. When I have more bruising like this, so this is quite extensive bruising, I'm really going to be looking more for an orthopedic fracture or a more significant avulsion fracture, perhaps an anterior process of the calcaneal fracture, something in this order that's going to have bled out to this degree. So this is an example of what happens on the medial side of the ankle when you have an inversion injury that separates the hindfoot from the tibia and fibula. You can see between the tibia, which is this bone here, and the talus is this bone here, we've got the tibio-talar part of the deltoid ligament complex. Now it's got this cystic area in it here. It's also got a couple of other little bony ossicles here, and these are little collision fractures where bits of bone have been chunked off. Some of these may be old and chronic, and I think these cystic areas represent change from the new injury where there's been further damage to the medial joint capsule. And then when we put the Doppler on it, you can see this is quite vascular. So if this is in the acute phase, I think this is post-contusion hyperemia. But if it's been persistent for a few weeks after the injury, then I'm happy to determine that this is a POMI lesion or a posteromedial impingement lesion, which is consistent with a more chronic type of synovitis that may then well lead on for months. The other injury that we see when we try and separate our hindfoot from our tibia and fibula is separation injuries of the deltoid ligament complex. You can see as I'm coming down through tibialis posterior here, you can see this sheet of white echogenic material here. And that's a piece of periosteum that used to be attached to the bone here. So this is a classic injury. And with a bit of transducive pressure, you can see how the joint capsule here has a bit of a cleft through it. I'll show you some more examples. So these are great examples. You can see this echogenic line here noodling through, and you can see the echogenic material on this side as well. So this is all periosteal stripping. So at the very least, this is the calcified fibrocartilage of the anthesis. And this has been stripped away from that medial malleolus of the tibia as the flexor retinaculum and the deltoid ligament have become separated from the bony architecture. You can see also the associated hyperemia. So I refer to these as degloving type injuries of the flexor retinaculum and the medial joint capsule from the medial malleolus. This is quite a dramatic one. You can see there's virtually no integrity left at all. Here you can see the synovial fluid just pouring out through a big open cleft in that medial joint capsule. And you can see the edema in the subcutaneous space as that synovial fluid has flowed freely into that area. So method 4 is when we separate our midfoot from our hindfoot. So this is called a Chopart line failure. And the first ligament that we'll see damage to here is the dorsal talar-navicular ligament. You can see a great example of it here. On the plane radiograph, you can see the avulsion here from the navicular end, and a nice little sharp shard of acute avulsion here. And if you look at it sonographically, this is the dorsal talar-navicular ligament, this is the navicular, and this echogenic area here with the shadowing, this is the corresponding avulsion injury that corresponds exactly to that shard of bone that's been pulled off there. So when I look at the dorsal talar-navicular ligament and I see an abnormality like this avulsion fracture, I immediately think that there's been a Chopart line failure, and I can't wait to have a look at the bifurcate ligament complex. So this patient has the classic bruise pattern where they've bruised out a lot on the lateral side of their foot here. And you can just imagine the anterior tubercle of the calcaneum, which is in about this location here, has been pulled off. And that's led to all of this bruising all on the lateral side of the foot. And there's the avulsion fracture there. You can see quite a large piece has been pulled off. This is the area here where the calcaneocuboid ligament lives, and it's the proximal end always that fails. And there's the large avulsion. Here's some more examples, and these go missed all the time because you can't really see them very effectively on a standard plane radiographic series. They tend to be overshadowed by other bony structures, but on the ultrasound, it's a really easy diagnosis to make. And another interesting anatomical point is this muscle here is the extensor digitorum brevis muscle here. It's the only muscle on the dorsum of the foot. And if you're in the right spot, you should have the anterior tubercle of the calcaneum and the calcaneocuboid ligament covered over by that muscle when you're anatomically correct. So this is a Chopart line failure. And you can see if we look at the anterior tubercle here, you can see there's the avulsion fracture at the bifurcate ligament origin. And now if we go across the foot to the dorsal talar-navicular, when we arrive here, we can see this looks very soggy and swollen as well. In fact, if you compare it over here, there's the symptomatic side with the asymptomatic side. You can see there's been a significant injury, perhaps not a complete failure, but a high-grade strain of that dorsal talar-navicular ligament. And this brings us to method 5, which is failure through the Lisfranc line. In other words, it's a separation of the forefoot from the midfoot. And this is not really an ultrasound diagnosis. It should be made with a DP weight-bearing radiograph of the foot. And what the radiologist will be looking for is the gap here between the base of the second metatarsal and the medial cuneiform. And you can see here how it's very wide, and there's probably a couple of little shards of bone that have been pulled off in here as well. So this is a classic radiographic finding of a failure of the dorsal Lisfranc ligament, and this is as a result of a separation of the forefoot from the midfoot. This is the corresponding ultrasound. You can see there's a complete derangement here of the articulation between the second metatarsal base and the medial cuneiform. Just a large hematoma. There's little bits of bone that have been pulled off everywhere. And you can see how wide this articulation has become. It's normally a very narrow little space with a very tough little collagen ligament. And here's another example that I've seen also, and in this case, you can see the medial cuneiform has actually suffered an avulsion fracture. So this tough little ligament, and this is a really classic sort of an appearance here. There's the ligament there of the dorsal Lisfranc ligament, and you can see it's still attached to the second metatarsal base, but at its medial cuneiform end, it's simply yanked this piece of bone off, and there's a little avulsion fracture there, and this patient will have significant bruising. And this has, of course, dissipated that energy by separating their forefoot from their midfoot. We do miss things with ultrasound. These are the things that are really not the scope of ultrasound. And I think if we have a normal ultrasound, it's worth considering talar fractures, other fractures, of course. We don't see bone bruising with ultrasound. I think the posterior inferior tibiofibular syndesmosis injuries, I'm getting much better at. And I'm also getting better at the interosseous membrane injuries, but I still feel like these are better seen with the other cross-sectional imaging modalities. And of course, chondral injuries, you can't really appreciate with ultrasound either. So we do have some blind areas, but celebrating our strengths and accepting our weaknesses or limitations, I think, is how we do good ultrasound. Here's an example of us having a small triumph with an unexpected fracture. We're looking at the base of the fifth metatarsal here with peroneus brevis inserting, and my peripheral vision just can't help but notice that the cuboid bone has a little step in its cortical architecture here. And this, of course, ends up looking back at the plain radiographs. They look quite normal, but the cross-sectional imaging shows an orthopedic fracture of the cuboid bone. So it's a really nice little pick for the ultrasound. I hope you've enjoyed this presentation. I think this is a really nice way of thinking about how energy is dissipated during an inversion injury to the ankle and the patterns that develop and the method to go about assessment of these patients. Please visit birdultrasound.com.au and take advantage of the coupon code BONE. When you arrive at the website, you'll see there's material on all sorts of ultrasound topics, not just musculoskeletal material. I hope you enjoy it. Thanks for the invitation to present at your meeting. Happy scanning and bye for now.
So, terrific. So we're back live, and I just want to thank Steve again for taking time out of his busy day to spend time with us. That really is a masterclass of evaluating the ankle. If anyone has any questions, just please ask aloud, and just be reminded that you are being recorded right now. So if you prefer not to be recorded, you can feel free also to type some questions into the chat, and Karen will retrieve those for us. So does anyone have any questions to ask Mr. Bird?
Fire away.
Oh, I see Mohammed has his hand up. Just go ahead, please.
Yep, go for it, Mohammed.
Thank you. Hi, do you hear me?
Yes.
Okay, thank you very much for this excellent presentation. I just want to ask you about if we have a calcaneocuboid ligament injury, can we talk about Chopart strain? And are there any relationship with a rostral fracture?
Certainly, when you have a calcaneocuboid injury, that is part of a Chopart line failure. And so the other key ligaments to have a look at when you have that disassociation between the midfoot and the hindfoot, the dorsal talonavicular ligament is another obvious one that typically will fail in the same injury. And then very commonly you do have some orthopedic injury as well. So once your midfoot moves separate from the hindfoot, it's almost a given that you will lose the anterior tubercle of the calcaneum. So this will become a significant avulsion fracture. Very difficult to see on the plain x-rays. You need to have it sort of skylined at just the right angle. So even in retrospect, once you've seen it on the ultrasound, when you look at the plain x-ray series, you really can't convince yourself of a fracture there. When you do a CT scan or an MRI, it's very obvious that you've got often quite a large piece of bone that's come off. And that's why you get such an impressive bruise. When I see these patients with extensive bruising on the lateral side of their foot, not just swelling, but extensive bruising, I really feel that the Chopart line is in play as a potential failure line. And then also the dorsal talonavicular ligament, when that fails, it's really common for that to take a piece, not so much of the talus, but certainly the navicular comes off at the same time. So you can have two significant little avulsion fractures, lots of bruising, and that Chopart line failure. The patient will really, hobble in on, moon boot or something, or on crutches. They'll be in quite some distress, have a lot of bruising, and you can almost make the diagnosis clinically or with your thumb if you just put your finger on that anterior tubercle of the calcaneum. They're exquisitely tender there. You know what you're going to find almost before you. I like to play this game where I try and work out what I'm going to see before I put the probe on the skin. If I'm working with another sonographer, I'll tell them, I say, this is what I'm going to see when I put the probe on, just based on the clinical presentation, and put the probe on and see how good your Nostradamus skills are, see if you get it right. Another thing that can cause that same sort of bruise pattern is base of fifth fractures, because they're very close proximity, of course, to the Chopart line, and so they'll bruise out in a very similar area.
Oh, thank you very much. Thank you very much. I have a second question, please, if you have time for answer.
Of course, go for it, Mohammed.
Oh, thank you. If we have, for example, deltoid ligament injury, how many times we can develop, for example, an anteromedial impingement syndrome, please?
I think it's really common. When you have a deltoid ligament injury, what happens is your medial malleolus really collides with the medial aspect of the talus. And that's quite a deep gutter, and it's filled with the deltoid ligament complex. Now, particularly in the posterior part of the deltoid ligament complex, which is the tibio-talar component, the collagen that sits between the tibia and the talus there, it's a really rich, deep, triangular shaped piece of collagen. And when it gets that collision injury, the medial malleolus really does contuse that deltoid ligament complex significantly. Now, when you look anatomically at what that medial joint capsule is made of, it's made in two separate layers, and you can appreciate it on the ultrasound. You certainly see it very well on the MRI scan, where the superficial layer is made of very dense, almost pure collagen. Now, that doesn't really get bruised so much, but the deeper part of that medial joint capsule, the same part of that tibio-talar deltoid ligament, is made of different structure. It's got some collagen in it, but it's got quite a bit of fat in it and quite a lot of synovium. Now, when synovium gets a compression contusion injury, it then very commonly then progresses to having a chronic synovitis. It's almost like it holds a grudge, like it has a memory. Once it becomes traumatized, the synovium will become synovitic. And so if I see these patients in the first few weeks after their injury, and it's a bit vascular there, and the spot that I use is I just come down the tibialis posterior tendon. The moment it leaves the medial malleolus and it's sitting on the joint capsule, the moment it does that, then that's the tibio-talar component. If I see vascularity there within the first few weeks of an injury, I just call that post-traumatic hyperemia. But once you get past about 3 weeks, then I think it's quite okay to call it a posteromedial impingement, so a POMI lesion. And this just represents synovitis. Now that synovitis doesn't have to be limited to that tibio-talar, more posterior part of the deltoid ligament complex. It can also extend to the middle part of the deltoid, which is the tibiocalcaneal part. And just depending on the vortex of force and the way that the ankle was moved, it can also involve the tibio spring or even the tibio-navicular component. So sometimes you'll even see that whole medial gutter has become traumatized. You get a really broad-based synovitis all the way down that medial gutter. And once you get that, I always think of synovitis a bit like a fire burning through a building. Is that, if the bedroom's on fire, then the room next door is going to start to catch fire as well. And once you have a medial ligament complex that's synovitic, then the tibialis posterior becomes tenosynovitic as well. So in these patients, it's not uncommon to see a tibialis posterior tenosynovitis and an associated deltoid ligament synovitis. And that's why they've got this persistent chronic pain on the medial side of their ankle. Even though the lateral ankle injury, the ATFL tear and the CFL have really healed up nicely and become much less symptomatic for them, their persistent symptoms will often be on the medial side.
Thank you very much for this explanation.
No worries.
I do have one question. I know we've reached the end of our time here and need to let you get back to work here, Steve, but I do have one question about the PTFL and whether this is anything that you are routinely looking at and how successful you are when you do.
Yeah, it's pretty easy to see. So if you just line up your posterior aspect of your lateral malleolus and then have the probe actually straight axial, so just dead straight axial, then that is the line of the PTFL. Another way to find it is if you find the CFL, so find the calcaneofibular ligament, and then if you follow that in transverse, what you'll see is just slightly proximal to that nice tubular CFL, you'll see what looks like, I describe it as like a zebra's skin. It's like a black and white stripy structure that's quite triangular, and it's just immediately superior to the CFL. That is the short axis that you're looking at of the PTFL. If you then turn the probe around, so if you're going to see the CFL in long axis, you're lining up the lateral malleolus with basically the apex of the calcaneum. Now, if you keep the fibular end of your transducer stationary there, move the other end around until you're perfectly axial, you're lined up on the PTFL there. So the PTFL is easy to see. It's a big, thick, triangular structure. In terms of inversion injuries, I don't see any efficacy or requirement for us to assess it, because if you work with pro sections, like I have the privilege to do fairly regularly, if you're trying to separate the hind foot from the tibia and fibula, the last piece of stuff you're sort of hacking through to get it off is the PTFL. It's almost impossible to tear. So I don't really see it as implicated in an inversion injury or traumatic scenario. But when I do have an interest in it is with my ballerinas. So with people that are doing ballerinas that are doing work on point, they will get posterior impingement problems. And the PTFL is one of the key structures that will get a nodular synovitis in those ballerinas. So when they're working on point, or you might even be a tradie, for example, that's working on ceilings or something, and you stand on your toes quite a bit, you can get posterior impingement. So if you've got a long stiter process on your talus, if you've got a congenital ostrigonum, then that sets you up to fail. And then it's really the PTFL part of the joint capsule that gets impinged in those posterior impingement patients. And then, of course, the FHL tendon, so flexor hallucis longus, gets involved as well. And that's really the constellation of findings I'm looking at with posterior impingement. So that's when I've got an interest in it, not with trauma injuries, but with posterior impingement. And using that technique I described, you can see it quite well.
That's fantastic. Well, I just want to thank you again for taking your time to be with us here today, and to thank everyone online for coming today. And we'll see each other again at the same time, same day next week. And I'll hand it back to Karen now for the final announcements. Thanks again, Steve.
Thanks, Luck. It's been a pleasure. Thank you.
Okay.
Thank you, Steve. Thank you, Dr. Louis. Just a couple of quick comments. Excellent presentation as always. I am in awe. Thank you. And excellent. Want to remind everyone that this talk is being recorded. If you did arrive late, a link to the recording will be sent out within the hour after the live lecture. And also, please fill in the assessment forms to get your CME credits. And next week, we have the pleasure of having Dr. Ali Gormazi from Boston University giving the talk on bone marrow lesion from trauma to degenerative disease. So look for the meeting invite to come later tonight or tomorrow morning, and we'll see you all next week. Thanks again.